on now? Okay.
Good afternoon. Welcome back to Grand Rounds. Please remember to sign the attendance record at the back of the auditorium, and also please remember to turn in your, actually fill in and turn in your program evaluations. And as always, I will request any ideas that you might have in regards to future topics or future speakers. Today, I have the privilege of introducing Dr. Michelle Mauermann. Dr. Mauermann attended medical school at the University of Iowa and did her neurology residency at the University of Virginia before traveling to the Mayo Clinic, where she did her peripheral nerve and neurophysiology fellowships. She stayed at Mayo Clinic, where she is a consultant in the Department of Neurology, and she's also an associate professor in the Department of Neurology, and she kindly has accepted our invitation to come down from Rochester today and provide us with an update on peripheral neuropathies and EMG. Please join me in welcoming Dr. Mauermann.
Thank you so much. Thank you for that kind invitation, and I really appreciate being invited to come speak today, and hopefully the review is helpful. So we're going to talk about a practical approach to neuropathy. We'll talk about the role of EMG in that evaluation. I do receive some research support from Alnylam and Ionis Pharmaceuticals for some industry TTR amyloid studies that we are doing in our group. So I just want to start out with two audience response questions. The first is, which of the following is the most useful screen for a peripheral neuropathy evaluation? The history, vibration testing using the 128 Hertz tuning fork, light touch testing using monofilament, or assessment of ankle deep tendon reflexes? You could answer now. Okay, I'm going to assume I click forward. Okay, so 56% said the history, and then kind of evenly split between vibration and light touch. So we'll go over that a bit more. And then the second question is, which of the following serologic tests has the highest yield in defining a potential etiology for a distal symmetric peripheral neuropathy? And you'll note that glucose isn't here. So we're looking at the second highest yield test. Heavy metal screen, vitamin B12, sedimentation rate, serum protein immunofixation, electrophoresis, or creatinine. Okay. And let's try again. It didn't come. Oh, there we go. So we had 42% vitamin B12 is kind of the winner there. So let's go through things a bit more. So just talking about peripheral neuropathy we use usually to mean disease or dysfunction of the peripheral nerves, and kind of use it sometimes as a general term, but sometimes we can really narrow down the focus into more specificity about what we're talking about. So if we're talking about the nerve roots as they leave the spinal cord, we're talking about a radiculopathy. If we're talking about multiple roots, it can be a polyradiculopathy. That can be from a structural cause, or it can be from a more sinister cause like infection or inflammation or neoplasm. Plexopathies are involving the plexus, and that can be sometimes hard to differentiate in the clinical setting. And then individual nerves we might use to refer to mononeuropathy, and we might be more specific, like saying the median nerve at the wrist, like in carpal tunnel syndrome, or the ulnar neuropathy at the elbow in cubital tunnel syndrome. Or we might be multiple mononeuropathies, and then that might kind of clue us into a mononeuritis multiplex, or something you might see in an inflammatory connective tissue disease, vasculitis. So the scope of the problem, so peripheral neuropathy is probably one of the top 3 to 5 diagnoses that we see in neurology, and a very common presentation, I think, in all of our clinics. And peripheral neuropathy, the reason we see it so much is it has such a high prevalence, so 2 to 3% in the general population, and as high as 8% in people over 55. And one of our colleagues at Mayo did a study looking at the prevalence in Olmsted County, and you can see here the red is women, and the blue is men. And you can see in the 7th and 8th decades, the prevalence in men even goes higher than 10%. So this is a common problem. And we want to focus on the evaluation. It's important because we can sometimes identify a treatment and prevent progression to disability in these patients. So we all know, so diabetes is the most common cause of peripheral neuropathy. It affects 20% of type 2 diabetics at presentation. And the prevalence, incidence increases with the duration of the disease, so affecting up to 50% of patients, and sometimes even higher if you just use electrophysiologic criteria. And we know that the diabetic neuropathy should occur in the setting of other microvascular disease complications, such as retinopathy or nephropathy. And if you don't see that, that should be a clue that maybe something else is going on. It also correlates well with the chronic hyperglycemic exposure. So neuropathy incidence correlates better with hemoglobin A1C than it does even with duration of disease. And the type of diabetes is also an important part, and so type 1 diabetics more common than type 2. So where do we see peripheral neuropathy, or where are we looking for peripheral neuropathy in our clinic? So there's two typical scenarios. One is you might be screening for peripheral neuropathy in patients who have a chronic disease in which peripheral neuropathy is common. So looking for this in your diabetic patients you're treating with chemotherapy that's known to be neurotoxic. Or in the patients who have a monoclonal protein disorder, dysproteinemia, like amyloid or multiple myeloma. The other case is patient might come in with symptoms that are suggestive of a peripheral neuropathy, and you want to be able to evaluate them and define who one can be evaluated and best treated by you, maybe needs referral to a specialty colleague, and really work on fine-tuning the differential and diagnosis and workup for those patients. So how do we screen for peripheral neuropathy? We use the neurologic symptoms, so there may be dead numbness, prickling, tingling, burning, electrical shock type pain, weakness. On the exam, complains of a steppage gait or tripping and stumbling when falling. Those are important. But we did an interesting study where we had 24 diabetic patients who were blinded, meaning that they wore dark sunglasses, caps on their heads. You can see they're all wearing scrubs, and they had a voice recorder that altered their voice. And so 12 of peripheral neuromuscular physicians evaluated these 24 patients on one day and then again on a second day. So we didn't know who was who. They were all diabetic patients, and we were evaluating them to see who we thought, by a very simple few history questions and examination, had neuropathy. We weren't allowed to ask them anything about their diabetes, duration of disease. And what we found was that we overestimate often the people who have neuropathy, and we're also variable. So we didn't do such a great job between one day and the next of who we thought. We were trying to be really overly sensitive for the diagnosis and not necessarily specific. So the neurologists do okay, but we're probably overestimating. So another study looked at another 240 patients with diabetes and used very comprehensive assessments. So they used a history and examination tool and found that 45% of patients had neuropathy. Then they looked at how well different markers were able to diagnose the neuropathy. So history alone did a poor job. Only 7% were diagnosed with neuropathy based on this gold standard group. Both the tuning fork and the monofilament did okay. They caught about 1/3 of the patients, and ankle reflexes about 1/4. So when we combined the tuning fork and the monofilament testing, they had a sensitivity for diabetic peripheral neuropathy greater than 90%. So using the monofilament testing, or we might just use a cotton swab or a tissue in the office, and the tuning fork are a good screen in your practice for looking for peripheral neuropathy. So we also then want to stratify the peripheral neuropathy, and you can do that a few ways. We can talk about kind of 4 questions. So what, where, when, and what setting. So the what is what modality is involved. So we think of as the peripheral nerve involves sensation, motor, and autonomic. Then we can talk about the where or the pattern. Is it a typical length-dependent neuropathy? Is it non-length dependent or multifocal? The when is, did the patient say, you know, the neuropathy started on, I remember last Saturday I woke up and I had this, or is it more of a gradual, insidious development of the neuropathic symptoms? And then what setting? And what setting is, you know, the other comorbid diseases or medications or family history may help in identifying potential causal factors for the neuropathy. So these are all helpful. Now, in reality, most neuropathies are length dependent. And most have a little bit of sensory problems, a little bit of motor, and a little bit of autonomic. You know, patients might say, well, they have a little bit of sensory loss on exam. They maybe have a little bit of weakness in the toes, and maybe they complain of a little bit of orthostatic lightheadedness or erectile dysfunction. And so sometimes more helpful is thinking the pattern. Is it length dependent or not length dependent or non-length dependent is helpful to sort these out, and we'll go over this a little bit more. We also stratify peripheral neuropathy using some electrophysiologic tests. So we call the EMG, which is really a combination of nerve conduction studies and needle electromyography, and then some autonomic studies. And again, we'll talk about these a little bit more in their roles later. So, you know, who might benefit from a specialty consultation? Well, patients who any patient who has an acute or subacute onset of a neuropathy would benefit. Those that are really progressive, so you see week by week, month by month, there's progression of their deficits, numbness, weakness. Those would likely benefit. And those, and even if they're length dependent, if they're really severe and functionally limiting, independent of any pattern or modality, those would likely benefit from a neurology consultation. Those also, any of those that have that non-length dependent pattern, so you might see the weakness is proximal and distal, so involving the thigh muscles and the foot muscles, or those that are multifocal, maybe right foot, left hand, those would benefit. And anyone that has a really modality specific, so a pure motor, pure sensory with like a sensory ganglionopathy or severe dysautonomia would likely benefit. Some pearls in the peripheral neuropathy history that can be helpful in identifying those that may be a more worrisome or ominous cause are, again, those that have a definite date of onset. So those subacute neuropathies or patients that say it started last Saturday and it's just been continually to be progressive, those often are immune, vasculitic, infectious, or neoplastic. So those are important pearls. Ones that have stepwise progression, so week to week, month to month, there's new accumulation of deficits. That can be a clue for multiple mononeuropathies, and we worry about those as having a potential vasculitic etiology. Those that are relapsing, remitting can sometimes be a clue that there's some sort of exposure, like a toxin, or we might see that in chronic immune demyelinating polyradiculoneuropathy, where we might see a more relapsing, remitting course. And also another clue is that positive neuropathic symptoms, so patients who complain of tingling or prickling or burning or sharp-shooting pain, those are more common in acquired versus inherited neuropathies. Inherited genetic neuropathies, patients more often have negative symptoms, so the lack of sensory symptoms, so dead numbness, feeling like there's a layer under their sock or something in their shoe, versus positive. So this might be what you'd hear in a typical length-dependent neuropathy from the history in your clinic. So a 64-year-old man has a 2-year history of numbness in the feet, starts in the toes, and has progressed gradually to the ankles. He has associated tingling, prickling, occasional shooting pain. And on examination, there's loss of vibration at the big toe, is decreased touch sensation to the ankle, and the ankle reflex is reduced. And there's normal strength exam and normal gait exam. So that was what we call a typical length-dependent sensory motor peripheral neuropathy. So in this case, it's primarily sensory on the examination. But sometimes even by electrophysiologic studies, you'll see some mild motor involvement. This is the most common type of peripheral neuropathy. We call it kind of the stocking glove distribution. And that's because looking here, when it's mild, you see the symptoms start in the feet, gradually ascend up the legs. When they get to the stocking level, then they start to involve the fingertips and then become kind of a stocking and glove distribution when more severe. In these cases, again, it's more sensory more than motor. Proprioception, so joint position sense, is generally more preserved unless it's severe. Weakness is usually involving distal muscles, so initially toe movement, then ankle dorsiflexion, distal movement of the feet. And the deep tendon reflexes are usually reduced in a distal more than proximally. So large fiber versus small fiber, I think this is a helpful distinction. We're seeing a lot of patients these days with small fiber neuropathies. And what do we mean by large versus small? So the large nerve fibers are your A beta fibers. They're the motor and the large sensation, so vibration and proprioception. The small fibers are your A delta, your C fibers, your unmyelinated, and thinly myelinated fibers, and they do more pain and temperature. So looking at symptoms and signs between the two, your large fiber peripheral neuropathies can sometimes be painful, but there's usually abnormal light touch, abnormal vibration. They may have proprioceptive loss and an ataxia related to their loss of joint position later. Weakness, often, but it can be mild. Reflexes are loss length dependent, and an EMG study, which we'll go into again later, is often abnormal. Small fiber, most things are preserved except for they're typically painful and they have abnormal pinprick and temperature sensation. But the other modalities are more spared. In small fiber neuropathies, it's helpful to think about, is there an associated dysautonomia? So the unmyelinated fibers can sometimes lead to autonomic dysfunction. And some questions you might ask in those cases is, do patients have early satiety, gastroparesis, erectile dysfunction? Do they have lightheadedness and they stand? Resting tachycardia, that can be the first clue in a diabetic autonomic neuropathy, is a resting tachycardia. Urinary retention, constipation. Rarely do patients complain of sweat dysfunction, but they offer that up if questioned. And then dry eyes or dry mouth are sicca symptoms. So what's helpful in the evaluation of a length-dependent sensory-motor peripheral neuropathy? So we know that with history and exam and electrodiagnostic studies and laboratory testings, we can probably find an etiology in 3/4 of the patients. Now you might say, no way do I find that the etiology in that many of the patients I evaluate, but with detailed testing probably can get to that point. That still leaves us with 1/4 of patients that are often idiopathic. And the good news and the bad news about that is, we can't find a clear cause, but the good news is that those patients have been followed for a long time and evaluated. We know that those patients usually have overall a very slow progression and more mild functional limitations. So even if we don't find a clear cause, that can be helpful in terms of telling them about their prognosis. So in terms of what tests should we do, the American Academy of Neurology has kind of put out a practice parameter on what tests are helpful in these more typical garden variety mild chronic neuropathies. And these are the tests that they talk about: a blood count, renal function, liver test, SED rate, some sort of evaluation for diabetes, either a fasting glucose, a hemoglobin A1C, or a glucose tolerance test. Thyroid studies, monoclonal proteins, B12, infectious studies for Lyme or HIV, or if you have high risk factors or you're in an endemic area for those etiologies, and then family history being often overlooked but a very important component. So we can see here that the highest yield tests are looking for diabetes. They're looking for the dysproteinemias, which is the second most common cause of a length-dependent neuropathy, and then B12. So checking for an SPEP will find about 9% of etiology in 9% of patients, versus B12 accounts for more like 2%. So how do we do? We know these tests are the most helpful tests, but how do we actually do with ordering those? And unfortunately, the answer is we don't do very well. None of us do very well. There's been several studies looking at this, looking at general practitioners, looking at neurologists, and we don't do very good at ordering these tests. We probably order unnecessary MRIs and up to 30% of patients. Only about 20% of patients in some studies get an EMG for an evaluation of a neuropathy. This study looked at the use of diagnostic tests in a cohort of patients. And the upper panel is looking at ones in the entire cohort. This one looked at patients where they were idiopathic, never found an etiology. And interestingly, we did pretty well in doing electrodiagnostic studies, either referring physician or neurologist, so over 80%. That's probably reasonable, because you can maybe argue if you have a typical diabetic neuropathy that maybe in those cases you don't need an EMG. But still, MRIs are ordered in over 20%. Still about a third to a quarter didn't get any testing for diabetes, any of the different tests. There's still a third that didn't get tested for B12 and half that don't get tested with an SPEP. So we can do better in terms of our evaluation for these patients. So let's talk about diabetic neuropathies in a little bit more detail, since again they're the most common cause. The most common diabetic neuropathy is the garden variety diabetic polyneuropathy. That accounts for 75%. But as you can see here, there's many different kinds of diabetic neuropathies. And I have listed here those that are symmetric and those that are asymmetric. And we'll talk about some of these in more detail. We have the diabetic autonomic neuropathy that again correlates with glycemic control. Neuropathy, whether or not it's associated with impaired glucose tolerance. Treatment-induced neuropathy, question about CIDP in diabetics. And then some of the more asymmetric, or the diabetic radiculoplexus neuropathies, which has also been referred to as diabetic amyotrophy. So diabetic peripheral neuropathy, again, is correlated with glycemic control, presence of other signs of microvascular disease or retinopathy and microalbuminuria, and then the type of diabetes, so type 1 again being more commonly associated than type 2. So if you don't see a neuropathy in the setting of other signs of microvascular disease or poor control, it should raise a red flag of should you be looking at for other etiologies of peripheral neuropathy rather than just the diabetes in these patients. The neuropathy of a typical diabetic neuropathy is sensory symptoms first. It usually is a length-dependent pattern again. It usually involves the small fibers first and then progresses to the large fibers. So they're often a painful peripheral neuropathy. And distal motor involvement comes on later. So then there's the concept of, is peripheral neuropathy associated or caused by impaired glucose tolerance? And I would say there's still some split in the field about this, although we'll talk about how it's kind of coming around. But Dr. Peter Dick at Mayo did a study involving our Rochester diabetic cohort that's been followed for a long period of time, and brought in a bunch of patients that either were normal controls or had impaired glucose tolerance or were type 2 diabetics, and reevaluated them, reclassified them into the appropriate groups, and really found that in the impaired glucose tolerance group and the controls, there was no difference in their prevalence of retinopathy or nephropathy. Only the true diabetics had an increased prevalence of neuropathy with the other associated features. So really did not show that impaired glucose tolerance was a particular cause. We know that though it can evolve to diabetes, and that should lead though to lifestyle modifications. More recently though, there's evidence kind of coming around the fact that impaired glucose tolerance in the setting of the metabolic syndrome with obesity, hyperlipidemia, hypertension, that is associated especially with the more painful small fiber type of neuropathy that is present in up to 10 to 30% of those metabolic syndrome type patients. So that the risk is higher there. And we know that in type 2 diabetics, it's not as much about treatment of the hyperglycemia as it is about treatment of the entire metabolic syndrome that helps with lessening those symptoms and even sometimes improving the neuropathy. So lifestyle modifications, weight loss, exercise being important in those patients. So another interesting diabetic neuropathy that's come out in the literature in 2015 is something that had been called in the past insulinuritis and had other names, but has been called at this point treatment-induced neuropathy of diabetes. And it's more common in the type 1 diabetics. And what it is it's a very painful, small fiber and autonomic neuropathy that's length dependent or become very generalized, as you can see here, that's associated with control of the hyperglycemia. And the risk is associated with how fast and how drastic that change in hemoglobin A1C is. So there's a tight correlation. So patients who had a change in hemoglobin A1C of 2% over a 3-month time frame had an 11% risk of having treatment-induced neuropathy of diabetes, and that risk only grew, as you see here, with the greater the drop in hemoglobin A1C over that time frame, the higher the risk and the significant worsening of pain scores and more generalization of the neuropathy findings in those patients. So the risk can be very great, like 50% if you change the hemoglobin A1C by 4 or more over a few months. Now, this is typically a much more painful neuropathy than we see in typical diabetic neuropathy. It's more refractory to treatment, and most patients require a variety of different pharmacological agents to control their pain, including narcotics, and still many report that they have inadequate relief. And it usually occurs with, we'd say, kind of in the time frame of 8 weeks has sort of been the definition of the glucose control to blame it on treatment-induced neuropathy. And it usually improves gradually over 12 to 24 months. Patients often have autonomic findings such as erectile dysfunction, orthostatic lightheadedness, nausea associated with this neuropathy. So it's important to keep in mind. So we want to control the hyperglycemia, but we may not want to control it too quickly. Another one that we see often is diabetic lumbosacral radiculoplexus neuropathy, which is also has had many other names. Another one here often is diabetic amyotrophy. And this one's a little bit different because it doesn't necessarily correlate with other microvascular complications, but this one is seen really in mild diabetics who are well controlled. And this syndrome usually starts with pain, bad pain. And usually it's more often lower limb than upper limb. So severe pain in the leg, often in the thigh. Patients will have a lot of contact sensitivity, so their clothes hurt when they touch their thigh. They complain of a lot of pain there. And then after the pain kind of subsides, or after a couple of weeks, pain becomes less of a feature, and then it becomes a weakness predominant syndrome. And again, it stays really asymmetric. Often in patients, it progresses to the other side, but it always stays very asymmetric. And it's usually femoral or sciatic predominant. So in the femoral cases, the patients may have quadriceps weakness, knee buckling, and hip flexor weakness. And in the sciatic predominant, it may be more of a foot drop presentation. And often these cases are associated with weight loss. So typically it's about 10 pounds or so, but sometimes could be much more drastic. And when these people are evaluated, the CSF is fairly normal. They have often elevated CSF proteins. And their MRI may show some bright changes in the roots or the nerves on T2. But on pathology, what we see is that this is really a microvasculitis. So around the blood vessels in the nerve, you see lots of inflammation involving the vessel walls. And this is bleeding, so this is hemosiderin that's depositing around those blood vessels. And so it's really an ischemic microvasculitis type process, again, in mild diabetics. And we don't know particularly what is leading to this because we know it happens in non-diabetics as well, but it seems to be more common in diabetics, or it's at least a recognized syndrome there. So what role diabetes is truly playing is unclear, but it's an important syndrome to recognize. So since we're talking about what tests are highest yield, we'll just keep going with some of the neuropathies that are associated with those high yield tests. So B12 deficiency, we see this a lot. It's probably about 2% of patients who have a low B12. We know that patients often can have functional B12 deficiency even though their B12s are on the low normal side. So we know that if we add a methylmalonic acid that we can increase the yield for finding true B12 deficiency as the cause of neuropathy to about 9%. And the B12 neuropathy can be just a distal sensory type of neuropathy, but because there's often association with the posterior columns, and the corticospinal tracts, that they could present also with ataxia. And due to the myelopathic involvement, patients may often complain of simultaneous onset of sensory symptoms in their hands and feet. And so that can be a nice clue, because most neuropathies should start, length dependent, should start in the feet and don't progress to the hands until they're quite prominent there. So the onset of both together can be a helpful clue. Also, sometimes just a very subacute onset of these symptoms is a clue. And we know that B12 deficiency, occurs in patients who have dietary limitations, either vegan diet, they just don't get enough B12, or they may have malabsorption, maybe prolonged proton pump inhibitor use, maybe autoimmune causes, resection of the ileum of where you might absorb the B12. So all of those things can contribute to development of B12 deficiency. On exam, again, you may see a mix of upper and lower motor neuron signs. So a patient might have absent ankle reflexes but have Babinski signs, so flexor or extensor plantar responses. So that can be a clue on the exam. So usually these patients have a macrocytosis, can have neutrophil hypersegmentation, and again, you might see a low B12 or a low normal B12 with an elevated methylmalonic acid. And when the autoimmune causes, it may be helpful to look for antibodies to parietal cells or increased gastrin levels. And this is typically a typical length-dependent axonal sensory motor neuropathy on the EMG studies, and we, of course, treat that with B12 replacement. And this imaging study here just shows the T2 hyperintensity that you can see in B12 deficient patients involving the posterior columns, here on the axial and on the sagittal image. So let's talk about dysproteinemias. So dysproteinemias are also a common problem. So we talked about how neuropathy gets more and more common as we age. So does the prevalence of monoclonal proteins. And so, odds are going to have it that as we age, there's going to be a number of cases of which we find both a neuropathy and a monoclonal protein. And, is it the causal problem for the neuropathy? So we know that dysproteinemias occur in up to 10% of patients with a peripheral neuropathy. And how to test for a dysproteinemia? So most of the time what I see is patients get just a serum protein electrophoresis or just an SPEP. And we know that 17% of all monoclonal proteins are missed by just doing an SPEP, so that you really need to do the immunofixation. And sometimes even and also the addition of free light chains can be helpful in some patients, in patients as well. So we also know that IgMs are important to catch for neuropathy, and we miss 30% of those by just doing an SPEP. So really encourage, in the evaluation of peripheral neuropathy, to add the SPEP with immunofixation into your evaluation. And why we want to not miss these IgMs is because the immunoglobulin type really matters in neuropathy. So we know that when we find a monoclonal protein, if we don't find another lymphoproliferative disorder or plasma cell disorder like multiple myeloma or lymphoma or amyloid, we just have what we call a MUGUS, a monoclonal gammopathy of undetermined significance, IgG is the most common one that we find, 73%. But if you just look at patients with neuropathy, it's IgM in 50%. So IgM seems to have something special associated with neuropathy. And we know that there's many types of paraproteinemic neuropathies. And there is a special, IgM MUGUS neuropathy, which we'll kind of talk about in more detail. That's more of your typical large fiber sensory neuropathy. Now, those can also be associated in a more systemic disorder like Waldenstrom's, macroglobulinemia, POMS, or AL amyloid. And the light chain, or the heavy chain and the light chain can be helpful in trying to figure out your level of suspicion for these disorders. The peripheral neuropathy type can be a helpful distinguisher. So we know that osteosclerotic myeloma POMS syndrome really looks like CIDP. We know that AL amyloid, again, is also a lambda, and it is often sensory motor or can just be small fiber, but has prominent autonomic involvement. And the electrodiagnostic findings can be helpful. A lot of these are demyelinating when they're associated with the monoclonal protein. So finding that and using your electrodiagnostic studies can be helpful in trying to sort these out. And we'll show an example of that in a little bit. So lastly, I just want to touch on hereditary neuropathies, because I think this is something that's easy to overlook. We're in busy clinics and we only have a limited time to see people. We can't examine often all their family members, and they don't bring people with them. And hereditary neuropathy is just one of those things that you don't really discuss at Thanksgiving dinner with your family. You're not talking about your feet and what your feet look like. So I think, it's just important to touch on this. Dr. Dick did this great study in 1980s where he saw over 200 consecutive patients who had an undiagnosed peripheral neuropathy and did extensive evaluation, history examination, and extensive sensory testing, EMGs. And once doing that, was able to define an etiology in 3/4 of the patients. 25% remained unclassified. However, when looking at 42% were identified to be due to an inherited etiology. And so how do we find that? Well, often it's asking the patient, after the first visit, go back and talk to your family members. Ask them what their feet look like. Ask them if they can walk on their heels. Ask them if they have any numbness or sensory symptoms in their feet. It's not always that you're going to get this information on the first visit, but something that sometimes information's accumulated over time. We know that hereditary neuropathies are more often motor than sensory, and that's why they don't often get complained about and we don't get the family history, is that these cause more dead type numbness, so they're not the painful type. And so often they don't come to attention until the weakness has gotten enough that it's causing functional limitations. There's enough foot drop, people are tripping and stumbling. We also know that 30% of these are de novo with no family history and that are genetic neuropathy. So we're not, even if we try, going to get the family history of symptoms. And we also know that these are heterogeneous. So there's genetic heterogeneity in that you can have the same gene, same problem, and have different phenotypes. And you can have the same phenotype with different genetic mutations. So it's not perfect that one equals the other. And then in families, some patients can be very mildly affected and others can be more severely affected at a younger age, and they have the same genetic mutation. So this is the typical foot that we might see in a genetic neuropathy. This doesn't mean a patient has a neuropathy, but it's a helpful clue. So we see what's called pes cavus deformity. So you have this high arched foot, hammering of the toes. And then you have very thin stork-like legs. People refer to this as an inverted champagne bottle leg appearance. So patients might say, I sprained my ankles frequently as a kid. You talk, were you a fast runner? Did you finish at the front of the pack, the middle, or were you always at the end? Some of those things can be helpful clues that you can gather from the history. And then the EMG is really helpful in distinguishing what's the type of hereditary neuropathy or Charcot-Marie-Tooth. We know that the type 1 are demyelinating, the type 2 are more of an axonal pattern. And genetic testing is probably the most helpful in demyelinating. We can find the mutation in greater than 90% of patients. And so genetic testing in the demyelinating is particularly helpful. In the axonal, maybe about 50%. But the good news about genetic testing is it's just becoming less and less expensive. So where we used to have to really think about which one gene, now sending a panel of genes for hereditary neuropathy is probably about the cost as it used to be for one. So I think we'll be learning more and more and finding more of the mutations that cause these disorders as time goes on. So other causes to consider in a link-dependent: vitamin E deficiency, fat malabsorption, copper deficiency, looks a lot like B12. It's a myeloneuropathy, again, with a malabsorptive history. Toxic neuropathy, so medications, think about acute or subacute onset, think about hand symptoms at the same time, and GI symptoms. Celiac's kind of always out there. I think the most recent case study looked at a really large cohort of celiac, and the incidence of peripheral neuropathy was low. So I would just say it's probably a rare cause, or it doesn't happen in most patients with celiac. But think of it when there's GI symptoms or an ataxia. And again, the anti-tissue transglutaminase antibodies are the most sensitive in adults for evaluation. So medications, you could look at a book and find hundreds and hundreds of medications. This is kind of just a short list. Again, the chemotherapies being ones that we see most often, they are often a painful sensory neuropathy. Some can have, like vincristine, a lot of motor or autonomic involvement, and they can coast. Some of them can coast, meaning even after you stop the drug, the neuropathy continues to get worse. And that's like oxaliplatin is probably the most likely that we'll see that. Flagyl, that's one I've seen in patients who've had extended long courses for C. diff treatment that I've seen patients get neuropathy associated. Amiodarone can cause a demyelinating neuropathy. Hydralazine is sensory, but it's often caused by a pyridoxine deficiency, so you can treat that with B6. But also B6 can cause neuropathy in high doses. So, you know, there's lots of different medications. Those are some of the ones that we maybe think of more commonly. And then other causes to think about in small fiber neuropathies. So hypertriglyceridemia is one, and that whole metabolic syndrome that's sort of been independently identified, but we don't have a particular level that we think about with that. Certainly the HIV-D drugs, amyloid, Sjogren's as a SICA symptoms. You might check the SSA and SSB antibodies to evaluate for that, but that's a typical small fiber sensory neuropathy. And then there's some other less common causes here as well. Now, recent studies have said that small fiber neuropathy is the most frequent neurological neuropathy associated with sarcoid. So we know it causes radiculopathies and radiculoplexus neuropathies, but maybe small fiber might be the more common. So just thinking about other the non-link dependent types, so polyradiculoneuropathies, that's when we're talking about that when there's root and nerve involvement, and the clue to that is that there's proximal and distal weakness. There may be cranial nerve involvement. They're much more motor than sensory. They come on subacutely. They may have relapsing, remitting type phenotype. The protein in the CSF might be elevated, and you might often sometimes see the nerves themselves are enlarged. Like if you did an MRI of the lumbar spine, you might see the nerve roots are enlarged. And these are important because they're potentially treatable. And there's a list here of potential causes. The ones in yellow are the ones that may show demyelination on the EMG. So that can, again, be a helpful thing to distinguish which list of causes are you going to be most focused on in your evaluation. And of course, these, we really want to see these in clinic. As neurologists, we like to see all neuropathies, but these we maybe have a potential of helping. So CIDP is one of the more common ones where we see symptoms and deficits come on over greater than 8 weeks. That's what helps differentiate it from the more acute form or Guillain-Barré. And the course is often progressive. It can be a monophasic course. It can be one that's lifelong. It can be progressive more in older patients that present with CIDP. In younger patients, we may see that more episodic relapsing phenotype. It's by definition a symmetric process. It's proximal and distal. They're often areflexic, and they have, again, the CSF protein. And the key finding is that you see demyelination on nerve biopsy. So you see here, these are little, what we call onion bulbs. So there's layers of Schwann cells around each of these little donuts as a nerve fiber. So we see findings on the nerve biopsy that show demyelination. So multiple mononeuropathies, again, don't miss evaluation in your neuropathy. So you get the history of this asymmetric or starting on one side in one nerve territory, and it's stepwise and it progresses to different areas. Now, if you don't get that history, by the time you see it, it may look like a confluent peripheral neuropathy, just a length-dependent, more symmetric process. So dialing down the history and how it really came on in terms of did it start on one side and then progress is really helpful. And then again, here are some causes, vasculitis being the top one on the list we're concerned about. And then the one in yellow, multifocal motor neuropathy, involves individual motor nerves, and that's a demyelinating. So that's why it's in yellow there. So what is EMG? So EMG, it concludes, again, the nerve conduction studies and the needle exam, and it has a sensitivity of 70% for a length-dependent peripheral neuropathy. And what does the EMG provide? Well, it confirms the diagnosis, one. So if you see someone in clinic and they're complaining, say, of hand numbness, hand tingling, and you examine them and you think, well, I think this is more likely due to peripheral neuropathy based on the findings I see, but maybe it's really carpal tunnel, but they also have some neck pain, and could it be that they have cervical radiculitis, and that's the cause? So that the EMG can be helpful in confirming where it really is the localization. It also tells us the extent of involvement. So is it just distal and length dependent, or is it this proximal distal? Is it more multifocal than we realize? And then it also provides unique information that we can't get from the history of the exam. So we can't tell by just evaluating someone if it's axonal or demyelinating. And then for some, we even can use it to follow with treatment. It gives us more prognostic information and tells us how well they're doing with their treatment as we reevaluate them ongoing. So again, we have the surface nerve conduction studies and we have the needle exam. So for nerve conduction studies, you apply a stimulus to a nerve, and you measure a waveform at another point. So in motor studies, you record over a muscle, and sensory studies, you record over another point on the nerve. We assess different things like the amplitude, how big is the response, how long is it taking time to get there, and is it involving more? Is it getting there very slowly? Does it take longer to get through the distal aspect of the nerve? So again, the compound muscle action potential, that's the motor response. We're stimulating a motor nerve and recording over muscle. And so it reflects not only the muscle, but the axons, the neuromuscular junction, and the muscle are all recorded by what we call the CMAP. This is what it looks like. You have a stimulator, that's the cathode and the anode, and here we're stimulating at the median nerve at the wrist and recording over the thenar muscle, the abductor pollicis brevis. Sensory studies, again, similar in concept, but you're stimulating over a sensory nerve, and because there's no muscle target or a sensory target, you record over the same nerve at a different site. And so here is what we would do for a median sensory study. Again, we're stimulating at the wrist and recording over the index finger, which is the sensory territory supplied by the median nerve. We also do the needle exam, which evaluates the integrity of the motor unit. And so you see here one motor unit, and it goes to many different muscle fibers. And so we look at different parameters on the needle exam that tell us if we've lost muscle fibers, if we've lost motor units, and others are coming in to reinnervate different areas. And so we can kind of see some information about that etiology. So here's how we might use EMG. So here's a 66-year-old man who has a novocaine feeling in the ball of his foot, first on the left and the right. He has hypersensitivity and unsteadiness, and numbness in his fingers and shock-like pain. His exam really shows length-dependent findings. Motor exam's fine, his reflexes are absent at the ankles, and he has mostly large fiber sensory loss distally. And he's got a little bit of positive Romberg and trouble with his gait. So this is a length-dependent, sensory-predominant neuropathy. You think, okay, well, we think about our regular causes. So we do our labs, and these labs are normal, the glucose, the B12. But we find a monoclonal protein, an IgM kappa. We want to know, is it related? Is it the cause here? Well, in this case, the EMG can be helpful, and this is extremely busy, but here is where we have our nerve conduction studies, and one of the parameters we look at is this latency. And what we see on this person is that in this man that all of the latencies, how long it's, the distal aspect of the nerve here is conducting, is very slow. So this is something we would see in a demyelinating neuropathy. So this is an IgM neuropathy that's been referred to as distal acquired demyelinating sensory neuropathy, or DADS-M. And it typically affects men in the 6th to 9th decade, and it's distal progressive symmetric neuropathy that preferentially affects large nerve fibers and causes a sensory ataxia. There can be mild weakness. It could even look like a CIDP, very proximal and distal in some cases. And so, in this case, it really helped us identify the etiology of his link-dependent neuropathy. It's important because we found a monoclonal protein, and you want to make sure that there's no other plasma cell disorder. And then it's potentially treatable. For this patient, because his deficits were mild, first we just monitored him for a year to see what's the natural history, because some of these people really don't worsen over time. So we monitored him, and he gradually got worse in terms of weakness, numbness, and gait imbalance. His EMG continued to show worsening demyelination. And so then we treated him with IVIG. Additionally, we gave it for 5 days, and then we gave it weekly. And we've over time been able to taper him. And he's improved. He initially when he got to his worst point, he needed a cane. He couldn't walk in crowds anymore. He had a significant sensory ataxia, and all of those things got better with IVIG, and he's been maintained on treatment. So even for those link-dependent, sometimes we find a cause that's potentially treatable, and the EMG here really was helpful. So just a quick thing, EMG has some limitations. It can take in a subacute process 3 weeks for us to see the distal Wallerian degeneration. So early, it may not be quite as helpful as later. Dynamic processes, where you will get intermittent compression, can be normal. And old processes always remain, so it can make localization sometimes difficult when they've had many old structural radiculopathies. And the key point is that in a small fiber neuropathy, the EMG is normal. So we do have other autonomic tests to help with the small fibers. We can check sweating. We can look at how their heart rate varies with deep breathing. We can look at their blood pressure and heart rate profiles when they do a Valsalva maneuver, or we do a tilt table. In some places, you might be able to get a sweat test. They're not very often available, but we can look at sweating patterns. We put a powder on the body. We see how well they sweat. It tests both pre- and post-ganglionic, but this is what you might see in a distal small fiber neuropathy. Their feet just don't sweat. We can also do skin biopsies, which are more readily available. So now, you can just do a simple skin puncture, a punch biopsy, and no sutures, low complication rate. And you can assess the intraepidermal nerve fiber density. So we're looking at the interepidermal nerve fibers as they cross from the dermis to the epidermis. And here you can see there's none. And so that's helpful for looking for a small fiber neuropathy. It doesn't exclude all of them. Again, you're testing it most often at the distal leg and thigh, and so really distal neuropathies you might miss. But you can also look for things like amyloid, so that can be helpful in terms of cause as well. And then just lastly, we also sometimes do nerve biopsies. We might consider that for a neuropathy that's acute or subacute, multifocal, or severe and progressive. And those often you're going to have sent them for further evaluation because of those features. But we're doing it when we're thinking about things like vasculitis or sometimes CIDP in an atypical case, or infiltrative things like neoplasms or amyloid. So here's what you might see in vasculitis. You have this destroyed blood vessel by inflammation. It's occluded. Here you have congophilic material around blood vessels. This is amyloid. And there's really no role for biopsy in an idiopathic length-dependent axonal sensorimotor neuropathy for the most case. Really that's not when we're doing a nerve biopsy. It's when we're thinking about these more severe etiologies. So in summary, length-dependent neuropathies are common and usually can be evaluated and managed without specialty consultation. The highest yield tests in history are in the evaluation are diabetes, the SPEP with immunofixation, the B12 with a methylmalonic acid when it's a low normal level, and the family history. And that EMG testing can be really helpful, and it can help distinguish axonal and demyelinating neuropathies and help identify those cases that are more likely to be treatable. So that's all I have. Thanks so much. I'm happy to take some questions. Yeah.
If you suspect B12 deficiency, is a cerebrospinal fluid titer, is that helpful?
No, usually a CSF would not be helpful in that case with the posterior column. Even with the posterior column involvement, it's usually normal. Uh-oh. Any other questions? All right. Thanks so much.